The following podcast is part of a certified educational activity featuring Ann H. Cross, MD, FAAN, from Washington University School of Medicine, and Professor Javier Montalban from the Multiple Sclerosis Center of Catalonia. Access the entire activity and complete the post-test at peerview.com/BTV860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, and welcome to Exploring the Rationale, Results, and Real-World Clinical Potential of Bruton's tyrosine kinase inhibitors in the Management of Multiple Sclerosis. I'm Ann Cross. I'm a professor of neurology at Washington University in St. Louis in Missouri, U.S., and together with Dr. Professor Javier Montalban, who is the chairman and director of the Neuroimmunology Department and Neurorehabilitation at the MS Center of Catalonia in Barcelona, we're going to talk about this topic today. So I will present there are two master classes, Masterclass 1 and 2. I'll present Rationale for Bruton's tyrosine kinase inhibitors as therapies for MS, and then after me will be Masterclass 2, given by Professor Montalban, who will discuss the clinical trial results and some of the clinical trials that are in progress. So I thought I might start by mentioning that in addition to the four phenotypes that we've grown accustomed to recognizing: relapsing, remitting, secondary progressive, primary progressive, and progressive relapsing, we now have different phenotypes that describe the disease courses of people who have MS. And this was put forward by Fred Lublin and colleagues several years ago. For patients who have relapsing remitting disease and patients who have a single isolated demyelinating event, they would fall into the relapsing disease category on the left, and they could be either having activity, meaning activity on MRI or clinically, or not active. And then patients who have a progressive disease, which may be subtle or may be quick, that would include the old primary progressive, secondary progressive, and progressive relapsing categories. Those people can have activity on top of their progression, and so they would be active or not active, but in addition could have progression or not progression, so they could be progressing or they could be in a plateau. And I think these categories are useful, but some investigators would probably argue that progressive disease actually begins back in the earliest stages of relapsing disease, and we just can't measure it then. But I think what most investigators would not argue with is that the goals of our treatment with disease-modifying therapies in MS is to reduce the incidence and severity of relapses, decrease MRI disease activity, and slow or delay disability progression. And those three things, if you have none of that, you meet the definition of no evidence of disease activity 3. And several years ago, there was a meeting of about 120 MS specialists in Las Vegas where this concept was discussed. And by the end of the meeting, which was a couple of days, nobody dissented. Everyone agreed that this would be a target of therapy for people with MS, to have no evidence of disease activity 3. And there is also a no evidence of disease activity 4, which includes no atrophy faster than the background rate expected for the general population, but that's really difficult to measure. Most people don't have access to that, so we're not talking about that today. This is something that we can actually target in our patients. So right now we already have a number of approved agents for relapsing MS and a couple for progressive MS, and these utilize different mechanisms of action, which are listed on the right of this slide. We have the interferon betas and glatiramer acetate, which are the old immunomodulatory agents that are injectable, and probably have multiple different mechanisms of action. We have teriflunomide, which is oral and inhibits rapidly dividing cells, including activated autoreactive T cells. We have the fumarates, dimethyl fumarate, diroximel fumarate, and monomethyl fumarate that activate the endogenous NRF2 antioxidant pathways and are anti-inflammatory. We have the sphingosine 1-phosphate receptor modulators, which include fingolimod, siponimod, and ozanimod that sequester lymphocytes in secondary lymphoid tissues. We have oral cladribine, which selectively is taken up by lymphocytes and leads to their death. We have 3 categories of infusible agents: natalizumab, which blocks cells from trafficking into the central nervous system by blocking alpha-4 integrin receptors on the surface of activated cells, lymphocytes. We have anti-CD20 biologicals that lyse B cells in the circulation. And we have anti-CD52 alemtuzumab, which depletes a number of cells, particularly T cells, and has a lasting effect for sometimes years. So with all that, why do we need another category of drugs? There are several reasons why we need a new category of disease-modifying therapies with different mechanisms of action, and these are a few of them. I mean, we all know that individual MS patients are different, and they respond differently to disease-modifying therapies and may respond better to one mechanism of action than another. And for some people, there are medical contraindications to some categories of our disease-modifying therapies, or they're contraindicated for pregnancy and breastfeeding. The different disease-modifying therapies have different characteristics, as I just mentioned, like different delivery routes and dosing frequency. And depending on the patient, this may lead to suboptimal therapy or even affect their adherence to taking it, and certainly their quality of life. And then risk tolerance. Some of our agents are more risky than others to the health of the person or carry more risk, and that may, and different patients have different levels of risk aversion or risk acceptance. So we need more. And on this slide, I'd just like to mention that we recognize, as mentioned before, a sort of relapsing biology of MS and a progressive biology of MS, which was discussed in the slide about the Lublin phenotype. So on the left-hand side of this slide, we're talking about the relapsing biology, which we think in MS, but don't know for certain, begins external to the central nervous system. We think that autoreactive T cells, probably CD4 T cells, are activated by probably B cells, and I say that because of the effectiveness of anti-CD20 agents that lyse B cells that also recognize the same antigen, and because of that can pick up low quantities of myelin autoantigen. So that activates the T cells, and they're able to cross the blood-brain barrier, and the B cells can as well. And there in the central nervous system, which would be on the right of this slide, we have reactivation of those T cells by another antigen-presenting cell. Probably not in all cases is this going to be a B cell, because there aren't that many that traffic into the central nervous system. But instead, in the central nervous system, we have a lot of intrinsic antigen-presenting cells, or cells with that potential, and those are the microglia, which are a type of myeloid cell. So also on this right-hand side, you can see that this concept number 5 of reactivation, you can see that B cells can, if they see their antigen again, become plasma cells, differentiate into plasma cells, and make a lot of autoantibody. And then that process of activation of microglia and other glia like astrocytes can then lead to the progressive biology, loss of axons, even loss of neuronal cell bodies. So in terms of B cells, well, we know that they're important, and we know that primarily because anti-CD20 agents that lyse B cells and remove them from the circulation are extraordinarily effective in reducing relapses. but we don't know what the multiple roles of B cells might be in MS. We think they're involved in this presentation of autoantigen to autoreactive T cells in the periphery and then possibly in the central nervous system as well. They also can produce cytokines and chemokines, which could lead to activation of other cells. The B cells can, and the chemokines or that they may produce or induce other cell types to produce can bring in and recruit other inflammatory cells. As mentioned, B cells can produce autoantibodies themselves, and they can differentiate into plasma cells, which have been localized in the parenchyma of MS patients and make a lot of antibody. And B cells are also highly involved in the formation of ectopic lymphoid-like structures, which are primarily noted in the meninges of people with MS, and particularly have been noted in people with progressive MS. And these are related to chronic inflammation, these ectopic lymphoid-like structures, and they contain not just B cells, but other cell types, including T follicular helper cells. And what about microglia? So microglia are myeloid cells. They are highly related and share a lot of surface markers with macrophages and monocytes and other myeloid cells. But microglia arise differently than macrophages. Microglia arise from the yolk sac embryologically. And in the last few years, a lot of important understanding of what microglia do has been expanded. In this slide, we have on the left-hand side, the orange microglia are the homeostatic or healthy microglia in times of health. And what they do is to prune synapses so that neurons can more effectively make contacts. They phagocytose debris, and that may include apoptotic cells and may include myelin debris. But they also can become activated and take on what's called the damage-associated phenotype. They become damage-associated microglia, or DAM, and when they do that, they upregulate a number of transcripts, including ApoE and MHC class II, and they downregulate a lot of their homeostatic transcripts, which are shown in the down pointing orange arrow here. So they change, and in EAE you see a lot of DAM cells, damage-associated microglia, that have upregulated these pro-inflammatory cytokines and the ability to present antigen. So the rationale for going after Bruton's tyrosine kinase in trying to reduce MS activity and progression is the following. So in B cells, as shown here, BTK, Bruton's tyrosine kinase, occupies a critical and central role in activation. So if the B cell is activated through its B cell receptor, it must invoke the enzyme Bruton's tyrosine kinase, and that leads to B cell maturation and activation. So if you block that, then you block the maturation, activation, trafficking, adhesion to endothelial cells, as well as antibody production and cytokine secretion from these B cells that are activated. It stops that. In microglia, they are often activated through Fc gamma receptors, and again, Bruton's tyrosine kinase holds this central key role in the activation process. And if you block it, you block microglial activation and the production by microglia of pro-inflammatory cytokines and cells that are and the production of things like nitric oxide synthase or oxygen free radicals. So now I'm just going to discuss a little bit about what the potential roles for B cells and microglia might be in progressive MS. So progressive MS is sort of like an orphan disease part of MS in that we don't have great drugs yet for it. So we're hopeful that perhaps this might be one way to approach it. So here is a depiction of what happens in progressive MS. And as I mentioned, the ectopic lymphoid follicles that B cells are involved in are particularly prominent in progressive patients. So if you block that, you might expect that B cells, that these ectopic lymphoid follicles wouldn't be formed or lesser formed. But then also the microglia, as mentioned, can secrete pro-inflammatory cytokines and chemokines and these reactive nitrogen and oxygen species. And in addition, they can upregulate MHC class II and present antigens to CD4 T cells. So we think that what's depicted here is part of at least what happens during progressive MS. And in this way, if you blocked B cell and microglial activation, you might reduce progressive MS. This is theoretical at this point. But if you use BTK inhibitors as a potential treatment for progressive MS, you really would think that they should have to get into the central nervous system for this particular role. So here I'm showing a BTK inhibitor that's sort of a first generation that's already approved, but not for MS and not being studied in MS. But it does cross the blood-brain barrier, as we see here. So this is ibrutinib, and it's indicated for several different neoplasms listed here. But it also has been looked at in mice, and as far as crossing the blood-brain barrier, and it's been shown that it gets into the central nervous system in very similar concentrations to the blood, what's seen in the blood, and that involves different areas of the CNS. And it's being looked at now in primary CNS lymphoma. So we don't have any results on that yet, but it's under study. So what about the ones that are being studied for MS? This is tolebrutinib. It seems to have a good deal of CNS penetrance based on cerebrospinal fluid study. So this is from a study that was presented at ACTRIMS in 2019 as a poster, and it's 4 persons who took a dose of this, 120 milligrams, and then 2 hours later underwent a spinal tap, and the blood level and the spinal fluid level were measured at that time, and it was found that the spinal fluid to plasma ratio of free drug was actually over 2, so spinal fluid was greater, and the concentration that was achieved in the spinal fluid by this one single dose was enough to inhibit 90% of BTK in cultured cells in vitro. And then here's another abstract. This was from ACTRIMS in 2017, and this was looking at the effect of evobrutinib, also being looked at, and Dr. Montalban will be talking about this later, being looked at in MS, but in this study it was looked at in EAE, experimental autoimmune encephalomyelitis, a mouse model of MS. And here, several different doses, 1 milligrams per kilogram, 3 milligrams per kilogram, and 10 milligrams per kilogram were given to these mice. And on the left is immediately after the first dose, and then on the right is at the end of the 30-day experiment, and looking at levels in the brain and the plasma and comparing them. And as you can see, at the 30-day mark, when they ended the experiment and took the tissues, the brain, as well as the plasma, the levels were very similar in the brain to those in the plasma, suggesting that it crossed the blood-brain barrier well. So, and then in the recent MS Virtual 2020, just a couple of months ago, there were a couple of interesting presentations by young investigators that I thought I would mention. One on the left was by Ray Lee, who's a postdoc at University of Pennsylvania, and the one on the right is by Helena Barr, who's a postdoc at University of Colorado. So on the left, we had Dr. Lee's presentation, which had to do with human B cells in vitro and the effects of BTK inhibition on them. And the big takeaway for me from his talk was that BTK inhibitors actually decreased activation of B cells, human B cells in vitro, decreased their proliferation, decreased their expression of co-stimulatory molecules, which are needed for presentation to T cells, and their antigen-presenting cell function. And they seemed to reduce the expression of pro-inflammatory cytokines in vitro much more than anti-inflammatory cytokines. In fact, there was no reduction of anti-inflammatory cytokines by B cells, being IL-10. And then on the right was a study in mice done by Dr. Barr, which utilized two-photon microscopy, and she put a window into the cortex of mice and then used a focal demyelinating model that had been developed by colleagues there at University of Colorado, where they added MS patient antibody plus complement. They applied it to the cortex of these mice, and that led to oligodendrocyte death or loss and microglial proliferation. But when they gave these mice 24 hours in advance BTK inhibitors and compared them to mice that received control substance, saline, they saw that there was not that reduction in oligodendroglial cells. The BTK inhibitor had completely rescued these mice from the loss of oligodendral cells and the microglial proliferation in the site of this focal cortical demyelination. So both of these were pretty interesting. So in this slide, I'm just summarizing what I've just told you, which is that we need other disease-modifying therapies with novel mechanisms of action because we don't meet every single patient with MS needs right now. And we have a drug or a class of drugs, the BTK inhibitors, that have effects on both B cells, which are clearly playing a role in MS, and microglia, which are also clearly playing a role in MS. And these are oral agents, and they can hit two targets at once, and they have at least a theoretical potential for having a role of action and benefit in progressive MS. So now I would like to introduce Professor Javier Montalban, who is in Barcelona, Spain, and he's going to give Masterclass 2 on the BTK inhibitors in MS. What do the data tell us?
Well, thank you very much, Anne, and thank you for the wonderful presentation about the mechanism, the pathogenesis of MS and the mechanism of BTK inhibitors. So I will be talking about clinical trials. Essentially, we don't have still clinical practice with BTK inhibitors, and the first trial I would like to mention to discuss with you is this one. It's a phase 2 study with ibrutinib. It's a placebo-controlled study. We had also an active control group with dimethyl fumarate and different doses of ibrutinib, 25 once per day, 75 once per day, and twice per day. So the primary endpoint of this phase 2 trial was the number of gadolinium-enhancing lesions after 24 weeks. And then we had a number of secondary endpoints, but I would like to highlight the main one, that was the annualized relapse rate after 48 weeks. As you can see here, all placebo patients switched to ibrutinib 25 milligrams once per day after 24 weeks of the trial, and then after 48 weeks, all of them were switched to 75 once per day, and later on to 75 twice per day. So I'm not going to describe all the inclusion and exclusion criteria, just to mention here that we allowed patients to be 18 to 65 years of age, so not really very young, many of them, relapsing forms of multiple sclerosis that included SPMS as well, but they had to be active, they had to be to suffer relapses, and the EDSS score lower than 6. These are the baseline demographics and disease characteristics. Let me just highlight that the age was about between 41 and 43, let's say that. So it's not the typical age for relapsing remitting MS trials. They were a little bit older. Most of the patients were relapsing remitting MS, but still we had about 10% of SPMS. They were active, as you can see, just to indicate that about 40% of patients had gadolinium enhancing lesions at baseline. And the EDSS, let me just also say that the EDSS, the mean EDSS was between 3 and 3.5. This is the primary endpoint of the trial, the total number of T1 gut lesions at weeks 24. And as you can see here, both doses of 75, once per day and twice per day, significantly reduced T1 gadolinium enhancing lesions per scan versus placebo. This is the secondary endpoint, the efficacy at week 24 and week 48. And as well, I don't know if you can see my pointer here, but the magnitude of annualized relapse rate reduction was maintained over 48 weeks with evobrutinib 75 twice per day. That was the dose chosen. Safety data. Here you can see that the infection incidence rate was generally balanced across the study arms and for the duration of the study, and we didn't have any serious opportunistic infection. We had a number of grade 1 and 2 ALT elevations, some grade 3 and 4 as well, but all of them were reversible and none of them had clinical consequences. And this is the phase 2 open label extension up to week 108. And I'm not going to describe all the switching that you can see here in the slide. But the point here is that in the next slide, the annualized relapse rate at week 48 was maintained to week 108 with a dose of 75 twice per day. I think that was very reassuring. As well, another concept, I didn't show the figure, but based on risk of qualified relapses, patients started on lower doses didn't achieve same efficacy as those started at 75 twice a day. So again, probably early treatment with the highest efficacy drug is much better, not only for evobrutinib, but in general in multiple sclerosis. We had a maximum efficacy at 95% BTK occupancy. This is the first long-term efficacy data reported for a BTK inhibitor in MS. And the safety was similar to that we found at week 48. And the dose of 75 milligrams twice per day was not associated with increased infection rate. Let me just move on to another BTK molecule. This is tolebrutinib. This molecule was designed to access the brain and the spinal cord by crossing the blood-brain barrier. This was quite an original and brave, I have to say, design of the phase 2 trial. I also have to recognize here, to be honest, that I was not very convinced that this design was going to work, but it did, and it did work very well. So we have two different cohorts. Cohort number 1, starting with the experimental drug in different doses, and then followed by placebo. The experimental drug was given for 12 weeks, and the placebo ran in for 4 weeks. And the cohort number 2, we started with placebo for 4 weeks, followed by tolebrutinib for 12 weeks. So the primary endpoint, let me just go to the next one. The primary endpoint was the dose-response relationship assessed after 12 weeks of tolebrutinib for gadolinium enhancing lesions. And we compare the two active arms, or the two active cohorts with the placebo one. That was the primary endpoint, the number of new gadolinium enhancing lesions versus 4 weeks placebo. And we had a number of secondary endpoints as well, as you can see here. So Again, the inclusion criteria, the age, they were a little bit younger in general. They were active as well, and I will show you the demographic data here in this table. So the mean age was 37, 36, so a little bit younger than the previous trial. All of them were relapsing remitting multiple sclerosis. They were active, and in fact, 35% of the patients had gadolinium-enhancing lesions at baseline, and between 36 to 59% had a highly active disease, and that was defined by having one relapse in the previous year and one gadolinium-enhancing lesion as well. Here you have the results, quite impressive reduction of the number of new gadolinium-enhancing lesions with the dose of 60 milligrams per day. As you can see here, p-value was statistically significant, and the same finding for the new or enlarging T2 lesions. What about safety? This was a short trial, but it still was very positive, in the sense that 129 out of 130 patients completed the study treatment period per protocol, which is quite impressive. Only one serious adverse event, and that was a relapse, and the patient recovered completely. We had also 2 patients with an elevated ALT, higher than 3 times ULN, but both patients recover perfectly well and remain on the study. Other side effects, as you can see here, perhaps let me just highlight the headache that was more frequent in the highest dose arm, and also nasopharyngitis, the same thing. So, just to summarize what we have been talking about up to now, we have 2 phase 2 trials with 2 different molecules, and now there is an impressive number of large phase 3 trials. The Evolution 1 and 2, they are identical trials using evobrutinib in relapsing remitting multiple sclerosis. They compare evobrutinib against teriflunomide. Then we have the Gemini 1 and 2. Again, on this occasion, this is tolebrutinib. Patients are relapsing remitting, and the comparator is teriflunomide as well. And then tolebrutinib is also being tested in SP without relapses. I think it's perhaps Anne can correct me, but I think it's the first trial that I can remember on SPMS patients without relapses. It's going to be very, very interesting. And also tolebrutinib is being tried in patients with primary progressive MS. This is against placebo. Then we have fenebrutinib. I don't think we have a phase 2 trial of this molecule. There is two large phase 2 trials being planned in relapsing remitting MS. The comparator again is going to be teriflunomide, and one in primary progressive MS. And here they are brave enough to choose the comparator will be ocrelizumab, in fact. Well, this is just the design of the trials I just talked about. Just to say that all the relapsing remitting, all the 3 molecules of BTK inhibitors, they are running 2 identical trials on relapsing remitting MS, and they have chosen teriflunomide as the comparator. On the other side, let me just go here. There is one study on SPMS, non-active SPMS patients using tolebrutinib, and there is 2 other trials with tolebrutinib and fenebrutinib on primary progressive MS. So I think this is very good news, in the sense that we are checking if this molecule with a different mechanism of action, as Dr. Cross showed, in all the phenotypes that we have in multiple sclerosis. So let's see what happens here. And with this, I think that was my last slide. And do you want me to, I think we have a number of clinical scenarios. Do you want me to start with number one? So this is a clinical scenario. It's a 37-year-old woman with relapsing multiple sclerosis, diagnosed 3 years ago, but not treatment at all. And that patient had a recent relapse. And there are few gadolinium-enhancing lesions in the MRI, in the brain MRI. So questions to consider, and the problem is based on clinical trial evidence. We don't have any real-world evidence here, and we have only 2 small phase 2 trials. So be careful about this. I think this is a very appropriate patient to be treated with BTKi inhibitors. It's a naive patient with an activity. I guess that many of our patients in the phase 2 trials were like this. So I think I would probably suggest to the patient that this could be an option. And the question here is, what if the patient had no gadolinium-enhancing lesion? I think it's the same thing. If the patient had a clinical relapse and you decide to treat the patient, I think BTK inhibitor could be a good option in this case. Do you want to continue, Anne?
Sure. And the second scenario is a very, very similar case, a 37-year-old woman diagnosed with relapsing MS 3 years prior, but this time she's already had a treatment and failed it, dimethyl fumarate. So she has gadolinium-enhancing lesions and activity relapse despite taking dimethyl fumarate. So again, these drugs are not yet approved. They are still being studied, but certainly an oral BTK inhibitor has potential to help her. And I think it remains to be seen what the issues might be related to pregnancy and that sort of thing. So we would need to know that in a woman of childbearing age and what to counsel them on. What if the patient had no gadolinium-enhancing lesions? Probably I wouldn't think that would matter that much if she had a true relapse. She would still be suboptimally treated on dimethyl fumarate and might benefit from a change in mechanism of action.
Yeah, I agree. In fact, this is another scenario, completely different. 45-year-old man with primary progressive MS, diagnosed 4 years ago, no treatment yet. So it's a young man with PPMS. It's not clear if the patient is progressing, but let's say that the patient is progressing. Here we we don't have any data at all of the effect of BTK inhibitors on PPMS, so it's absolutely speculative. According to the mechanism of action that Dr. Cross showed in the previous talk, I think could be an option, but still we have to wait till the results coming from the 2 PPMS trials and also from the inactive SPMS trial will be ready.
Agree. I'll look at the next slide, which is a similar case again. 45-year-old man with primary progressive MS, has had it for 4 years, but he has already been on ocrelizumab, which is approved for primary progressive MS, but hasn't seen what he anticipated as benefit. And he missed his last appointment, probably because he's discouraged, and hasn't rescheduled yet. So again, the same issues. We still need to see the final data from the studies in progressive MS to know whether BTK inhibition is going to be helpful or not. But it might be, and in people who might not have achieved the benefit that was expected or wanted with an approved drug, if BTK inhibitors are improved for progressive MS in the future, then perhaps that would be an option. And now we will take a few questions from the audience and do our best to provide some answers. And we'll, Professor Montalban and I will make some final comments.
So I can read here. What are the important side effects of BTK inhibitors? Well, I will be just mentioning those which have been observed in MS patients, not in other diseases. I think infections don't look to be a problem up to now, but again, the number of cases is very small, so we have to wait for the phase 3 trials. But up to now, there is no red signals in relation to infections. The other problem seems to be the liver, the increase in the ALT, and up to now as well, the number of grade 3-4 has been really very small, and all of them recovered, and none of them had any clinical symptomatology. So luckily, we can say that coming from the phase 2 trials, the safety profile seems to be very good. But again, and I think we are saying this once and again, we should wait for the phase 3 trials. How will we justify placebo-controlled trials of BTK inhibitors in PPMS, given an existing approved drug? That's a very good question. I think, unfortunately, in many countries, ocrelizumab is not ready for patients with primary progressive MS. It's not available at all. So this is one thing. The second point here is that ocrelizumab is the only drug labeled to treat patients with PPMS, but the effect is moderate at most. So if we have a molecule with an interesting mechanism of action, I think that some patients, depending as well on the inclusion and exclusion criteria, the degree of activity, yes or no, etc., I think a number of patients will be happy, and a number of neurologists as well, to enroll patients in placebo-controlled trials using BTK inhibitors in PPMS, even in the Western countries. Difficult, but possible.
I agree. Unfortunately, the effects of ocrelizumab on primary progressive MS are not as good as one would like, and I think it will enroll in the West. I'll take the next question. What are the main potential benefits of BTK inhibitors in the treatment of MS patients? And maybe the next question is pretty similar. What is the role of BTK inhibitors in MS? And to me, the potential benefits, if they are approved, if they prove to be as good as the early studies have suggested, the main benefits will be we've got a new oral drug with a different mechanism of action, and one that crosses the blood-brain barrier, so has certainly the potential to act in the central nervous system, and it has this different and new mechanism of action, which is helpful when you have patients who have failed many different other mechanisms of actions as well. And of course, oral agents are much easier for patients to deal with than injectables for the most part. And I think the role remains to be seen, really, in terms of what the data shows, and particularly what turns out with the progressive MS studies. Do you want to take the next one, Professor Montalban?
Yes, of course. How do you determine if a BTK inhibitor is appropriate for a patient with MS? I think we don't. We don't know how to do it. I think we try to personalize our treatment, but unfortunately, we don't have any pharmacogenomic approach or anything like that yet. We just take into consideration the gender or the sex, the pregnancy, desire or status, the activity, prognostic factors, etc., etc. And this is the best we can do. And then probably taking into account all the mechanism of actions that Dr. Cross mentioned, and also if we wait till the results of the phase 3 trials, we will be able to choose the appropriate patient to be treated with BTK inhibitors. I don't know what you think. Anne.
Yeah, I think I agree with your answer.
Yeah.
We don't know yet, really. Do you want to take the final one?
Okay. Okay. Yeah, we can answer, the two of us, how we
Okay.
handle this situation in our clinics. I think, how do you explain all the newer treatment options, including BTK inhibitors, to the patients? We don't nowadays because again, BTK is not available in the clinical in our clinical practice yet. But what we do is probably we try to personalize our treatment as much as possible with all the factors that I mentioned just a few minutes ago. And then we choose few of them. We discuss all of them with the patient. On one hand, we provide written information as well. Then we present that case in our rounds. 12 neurologists discuss the case and discuss the treatment, and then we go back to the patient again and discuss all the possibilities and we try to solve all their doubts, etc. So it's not an easy process in a number of patients, but this is the way we deal with. Yeah.
Wow, that's pretty impressive. 12 different MS specialists looking at your case to decide.
Yes.
That's great. At our place, at least for me, I just try to get a feel for the patient. I sometimes ask them outright, are you a risk-averse person? Are you a person who would take risks in order to have a more aggressive therapy, even though it might have some risk for you? And we would go over them, but it's almost never in one single visit. It's to try to get a feel for the patient, what their plans are for the future, what comorbidities or pregnancy plans they might have, and then from that, I personally try to choose 2 or 3 categories or mechanism of action, and then the patient will come back to see me or our nurse practitioner in 3 or 4 weeks and have another discussion and try to make a decision then, but we don't push people to make a decision too quickly. We try to get to the best drug first so that we hope they'll be adherent and respond to it.
Yeah.
Doesn't always happen.
Yeah. That sounds pretty sensible, in fact.
Yeah. So, did you have any final comments, Professor
No, really.
Montalban?
Just to say that this is a new molecule. It's very attractive. Results up to now, preliminary results are quite good, I would say. Quite promising. Let's see what happened in the phase 3 trials. We have a number of them in all clinical phenotypes, which is very good, in fact. So let's see what happened.
Yeah, I think we've been very fortunate to hear from Professor Montalban, since he's had such a key role in these clinical trials and has a lot of firsthand knowledge of these drugs and how to use them. And I don't have any particularly erudite comments to make at the end, other than to say that it's always better to have more choices and to allow us more flexibility in individual patients. But we have to wait and see what the clinical trial results are, and particularly in the progressive patients, and we have to keep our fingers crossed that it will work in progressive patients where we need help.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/BTV860. This activity is supported by an educational grant from Sanofi Genzyme.